Thank you, Himanshu. And it's so great to see so many people attending our course, first day, first session. And I'm extremely delighted. And we have the few CDs for the delegates who stay till the end so that we can give you the presentations uploaded in the CDs. I'll be talking about corneal collagen cross-linking, which is C3R, CXL, CCL, whatever we talk. And if we look at the color images, I see that in the right side projector, the color is coming proper, and the left side projector, the color is not coming so proper. So when you're looking at the topographies and the pentagram pictures, I would prefer that you concentrate on your right, on my right side, on your left side, projection, because that will be giving you more accurate, picture on the color scale. The inventors of corneal collagen cross-linking is Theo Seiler, from which I learned the C3R and the technique and saw his, data and patients for over 10 years when I visited him. And there is a definite, hardening of the cornea after C3R, which is shown here with the cadaver cornea treated with the riboflavine and ultraviolet exposure. Basically, cross-linking is a physiological process, and stiffening of connective tissue is a well-known in aging and diabetics, and that is why diabetes is a protection factor against keratoconus. And during the cross-linking, new chemical bonds are introduced, as you see here, and when the cornea is cross-linked, the collagen bonds which are produced make the cornea harder and stiffer and stronger, so that the ectasia does not progress after the cross-linking. The indications are, as we all know, the ectatic conditions like keratoconus, pellucid marginal degeneration, and also iatrogenic keratectasias. And we all have done a lot of C3R in all these conditions. The primary requirement is that this has to be a progressive type of ectasia. We do not want to do anything. We jump upon the C3R when we first, see the ectasia. So we have to, document that it is a progressive disease before we go ahead, because, as I said, it is sometimes the age and time also, prevents the progress of the keratoconus. So it is very important to, do any active treatment before that. We have to be very sure that we are looking at the progressive disease. Also, the important fact will be the corneal thickness at thinnest location should be more than 400 microns, and the maximum corneal curvature should be smaller than 60 diopters. So we do not treat very steep corneas, because they are much better treated with corneal surgeries, and for which the other constructors will be talking about. The incidence of keratoconus is nearly 1 in 2,000 people, so it's 0.05% of the population, though no firm data is available for the iatrogenic keratectasia. But as Rishi had shown you earlier in the day, that ectasia is not only limited to the LASIK, it is also reported in the surface ablation. So we should be very, very careful, because majority of times what I have seen in my experience of refractive surgery over a period of 20 years, that majority of times the ectasia occurs when we miss the ectasia or early ectatic situations in the topographies pre-refractive surgery. I've yet to see a patient of ectasia developing after absolutely normal cornea, though there are reports. But when we look at those topographies very carefully, we find that all those were having a little bit of suspect situation from the beginning, and then only they developed the ectasia. So goals of the UV cross-linking treatment is to stabilize the cornea and to stop the progression of the disease, and that is what we achieve in 100% of the cases. This is such a fantastic treatment, and we can assure the patient that after the corneal collagen cross-linking, the possibility of the ectasia growing worse or progressing further is hardly any. Timing of the treatment, of course, of the disease is as soon as significant progression of the ectasia or the corneal thinning is discovered. So as soon as we find that there is a little bit of a progression over a period of, when we check them after 3 months or 6 months and find that there is a progression, must treat them immediately. Which diagnostic tool can be used to rate the efficiency of the treatment? The best tool will be the called topography or Scheimpflug imaging. Of course, Scheimpflug is the gold standard because it gives you the anterior and posterior float both. I am not so fond of OpScan, but there will be people who are more fond of OpScan, but I find the other topographers as well as the pentacam more appropriate. Also, we can judge as to when to start treatment is best corrected visual acuity. If it is deteriorating, called thickness. If it is getting lesser and lesser, and we can prove that it is getting slightly less over a period of time, and slit lamp examination of keratoconus level and classification. So all these clinical tools are important, but of course an imaging system is the first tool and the most important tool, so that you can treat the ectasia. And the patient should be positioned absolutely vertically down the ultraviolet, and the exposure size should be absolutely correct. It should be absolutely round, and it should not be diffuse or too close so that you can see the different shadows of the LEDs. The treatment step is local anesthesia, manual abrasion of 6 to 8 millimeter, riboflavine solution available in the market, drop every 3 minutes for 30 minutes. Observe clear fluorescence within the antechamber by slit lamp with the blue light. Irradiate the cornea with UV for 30 minutes, and during this time continue putting riboflavine and BSS to moisten the cornea every 5 minutes, and this has to be controlled visually. So this is how we do the abrasion of the cornea with a hockey knife. And what I am doing is a hash shaped abrasion, because it kind of heals faster. If you remove the complete epithelium, it takes longer time to heal. In all these cases where I do this kind of abrasion, it heals in about a day maximum, and the absorption of riboflavin is very quick and complete. And then we continue putting riboflavin, which comes in these syringes. What I use is a Peschke from Switzerland, and then we expose it with the ultraviolet for 30 minutes. And what kind of ultraviolet damage we are looking? If we look at the damage, the damage to the cornea occurs at 0.65 joules, and lens 7.0 and retina 7.7, whereas after the riboflavin it is mostly in the range of about 0.4 to 0.1, going from in front to back to retina, and that is how we see that it is very safe for the lens and the retina. The ultraviolet exposure does not cause any damage to the lens and the retina at all. And combined application of, I think did we start with 15 or we started with 10? 10. So this is 15 minutes. Yeah. So this combined application of UV and riboflavin will create a collagen crosslink because of the oxygen radicals, which will be something like aging of the cornea quickly, and that makes it harder and stiffer. And there are other agents which can cause cornea to harden, like glutaraldehyde and aldehyde sugar, but the safest thing is riboflavin, which with the wavelength of 360 nanomicron for 30 minutes, it increases the corneal tension by 80% in 30 minutes. So that is very important. 366 nanometer wavelength is the safest. It causes highest transmission of DNA and does not cause any photoconjunctivitis or blue light damage. And this is the absorption and tension, increase in the tension. So if you see in the ectatic cornea in the lower graph, there is no increase in tension, whereas after the treated cornea, you can, the cornea is hardened, so it can withstand more tension. Diagnosis is with the as Ashu has already talked to you regarding the Munson sign, Fisher rings, Vox tria, topography, Scheim-Flug, and the topography, as you can appreciate, he has already shown you a lot of topographies. Ectasia, normal keratoconus starts usually in the second decade of life, and subtypes are pellucid and keratoconus, keratotorus, keratoglobus with different temporal evolution. It can stop at any stage, and then it is called form-first keratoconus. Incidence is, we have talked about the incidence of ectasia, but 5:1,000 form-firsts are available if you are seen in the population if you look at the form-first, and it is 3 to 5 times more frequent than the progressive type of keratoconus. And after the collagen cross-linking, the maximal K readings were significantly reduced in 65% of the cases in our series. This is over a period of 2.5 years. So this is very significant. There's a lot of flattening of the cornea and improvement in the visual acuity. The beauty of the treatment is that it has no side effects, there's no adverse reactions, and progression was halted in every case, and as I said, there was a flattening in 65% cases. A progressive keratoconus thus can be transferred into a form-first keratoconus by means of corneal collagen cross-linking. And safety of cross-linking, as you can see, after 400 micron of cornea, there's hardly any ultraviolet radiation which goes inside. So the 400 micron thickness is the very important parameter. If you have a 400 micron corneal thickness, the rest of the cornea is safe and is not damaged because of the ultraviolet radiation. And you can see up to 300 micron there is loss of nuclei in the cornea, and then it regenerates over a period of 6 months completely. Initially the keratocytes are killed up to 300 microns, and it regenerates in 3 months time, and they become absolutely normal. So that is, and the endothelium cells also, initially you will find that there is increased corneal thickness, there is corneal edema, but the endothelium remains nearly irregular, but then it becomes absolutely regular endothelium, and the corneal edema reduces after 6 months postoperatively after corneal collagen cross-linking. So safety issues is, I will emphasize it again, the corneal thickness of more than 400 micron will be absolutely safe for cornea and the eye. And also there is a possibility that there is, when we have corneal melting, we can do a corneal collagen cross-linking, especially like these situations where there is an antibiotic or non-treatable, kind of corneal melting happening after LASIK. And then once you do corneal collagen cross-linking, this everything, because of the ultraviolet, the whole thing becomes stable over a period of time, and then you can go ahead and do DALK in these cases, and the results are absolutely beautiful. So in conclusion, a progressive keratoconus can be transformed into form-first by corneal collagen cross-linking, and corneal thickness of more than 400 microns is necessary, and corneal melting can also be stopped after the cross-linking. And here are few topographies to show you the results, and these are very early results. Early means this is of course 2008, a picture of 2008, but this is very early. In about a month's time, what you see is a beautiful corneal flattening and complete reversal of the keratoconus process in all these topographies. If you compare the left one with the right one, they are beautiful results. I have seen a flattening of up to 5 diopters of astigmatism in all these cases, and you can appreciate these topographies, that how good flattening has occurred over a period of time. Thank you.